This will be a video walkthrough of a neurologic exam. As you observe this video, keep in mind if you were recording an examination for remote interpretation, what are aspects of this recording you found helpful and parts that could be improved. When performing a neurologic examination, this is the general order it is performed. Depending on the patient, we might have to adapt. For example, if it is an aggressive animal and we are mainly concerned about a thoracolumbar myelopathy, maybe we save cranial nerves for after proprioception. Or if an animal presents stuporous or comatose, we would forego gait evaluation and proprioception. Starting with observation, although behavior and mentation are important to interpret with the exam, it is quite challenging to appreciate the subtleties on a video. That said, from the observation in this video, there are no obvious behavior or mentation abnormalities. Posture is abnormal at times. In person, the gait is quite abnormal in this dog. From the start, you can see that the right thoracic limb knuckles over, and each time the dog walks, you can see that the right pelvic limb will scuff. An in-person exam is helpful because you could more easily hear the scuffing too, and not just rely on seeing the abnormalities. We will let the video keep playing so you can appreciate that gait deficit. Eventually, when the dog tries to turn, his thoracic limbs start to splay out, and it is hard for him to get back to a normal position. Just based on this gait alone, I would be worried about either AC1, C5 myelopathy, or an intracranial lesion, and we would need the remainder of our exam to help try and differentiate that. Remember other parts we are observing, such as muscle symmetry in the head and limbs. For the hands-on part of the exam, we will start with cranial nerves. I generally start with the meniscus because it checks so many boxes in terms of the brain and cranial nerves when it is intact. Notice that this dog will meniscus in each eye, but the meniscus is not complete bilaterally. This could be related to a visual deficit, a lesion to the brain, or a facial nerve deficit. However, in this patient, it was behavioral. Ideally, when we come across a patient with a meniscus such as this, we should evaluate the vision in other ways, such as watching them walk off-leash, performing the table test, or performing the cotton ball test. Since we are looking at the eyes, the next part of the exam I generally perform is the oculocephalic reflex, again looking at each eye individually in each direction, and we should see the eyes click fast in the direction we are turning the head. Still sticking with the eyes, I perform palpebral next, assessing the medial and lateral canthus. For patients where we are concerned about cranial nerve 5 deficits, I will also perform the corneal reflex. However, some neurologists will perform this on every patient. At this point, we have assessed cranial nerves 2 through 8, cranial nerves 2 and 7 with the meniscus, cranial nerves 3, 4, 6, and 8 with the oculocephalic, and cranial nerves 5 and 7 with the palpebral. To further assess cranial nerve 5 sensation, we will cover the eyes of the patient and perform an irritating movement to the nose, such as placing hemostats in the rostral nasal cavity. We are looking for them to react, typically by pulling away. I will also assess other areas of the face to see if there is some form of a reaction, either with blinking or a behavioral response. I will also assess the inner pinny as this is the sensory portion of cranial nerve 7 is being assessed. So even though we had already assessed cranial nerves 2 through 8 with the initial part of the exam, we still perform a more thorough evaluation to look for subtleties, as sometimes the subtleties are the key finding in the exam. Next, we will assess the gag reflex, as this evaluates cranial nerves 9, 10, and the cranial branch of 11. Afterwards, most animals will move their tongue after the gag is performed, which allows us to assess cranial nerve 12. The last part of the cranial nerve exam I generally performed is the pupillary light reflex. This could be performed at any point in the exam, but because it requires extra equipment, I generally perform it last. Assessment of pupil symmetry should be performed in ambient room lighting, along with in a dark room. However, it is difficult to record the pupils with a camera phone in a dark room, so it is not shown here. Notice that when I perform the PLR, I will perform the direct in one eye, then quickly assess the indirect in the other eye. In a well-lit room, I will then cover the eyes for 10 to 15 seconds to allow for pupil dilation, then repeat on the opposite eye. The pupillary light reflex, even in the light, is very difficult to capture with a normal camera, but it is possible. Other parts of the exam not performed in this patient were assessing smell, airflow through the nostrils, the fundic exam, and the Schirmer tear test. I try and perform the airflow test and fundic exam on every patient, but it is nearly impossible to record the fundic exam without special equipment, and the airflow test is hard to capture on video at times as well. For most patients, I rely on history to let me know if there is a change in their ability to smell, and although the Schirmer tear test is part of the complete exam, as it assesses the parasympathetic portion of cranial nerve 7, we generally only perform it if there is suspicion of dry eye. That said, it is not wrong to perform in a patient that allows for it. The next part of my exam is assessing proprioception. As previously stated, sometimes I will perform proprioception first over cranial nerves, such as with an aggressive patient where I am most concerned for a myelopathy, so don't get too set on a specific order. It is more important to adapt to the patient versus making the patient adapt to you. In dogs, paw placement is generally where I start. Notice I am standing behind the dog, supporting some of the weight, but not too much weight. Comparing the left and the right, there is a clear difference with the right being completely absent and the left being mildly delayed. It is also okay to repeat the placement to be certain of the findings. Also, if you are recording the exam, make sure that the individual recording moves the camera so the proprioception can be visualized. Ideally, it is nice to see the response from the patient and the technique of the examiner, as this helps with interpretation and critique, but ultimately the response is more important. Next in this video, I will assess paw placement in the thoracic limbs. Again, I am supporting some of the weight, but not too much weight, and we can see a clear difference from the right side, which is absent, to the left side, which is normal to maybe mildly delayed. Sometimes I will perform paw placement and hopping in the pelvic limbs first before moving to the thoracic limbs, but in this patient it was more convenient to finish paw placement in all limbs first. After paw placement, we will perform hopping. When I perform hopping, I will pick of the limb opposite to the side I am assessing, by the humerus, versus the carpus like most people do. This is for two reasons. First, I am flexing less joints, and if this is an older animal with arthritic pain, they might show discomfort when you flex all of their joints. Second, it is harder for the animal to bite me when I am closer to the base of the neck. With me getting older, I am getting slower, so any advantage that I have to keep from getting bit, I will use. As you watch me perform hopping, notice that I am lifting the opposite limb I am evaluating, having the animal bear weight on the limb being evaluated, then moving that patient laterally. Once again, the right limb is severely delayed compared to the left. When performing hopping, the limb should not pass midline prior to the animal trying to correct it. With the right limb, I can get well past midline before an attempt is made, and sometimes there is no attempt at all. This is in stark contrast to the left limb, where you can see how quickly the patient corrects their limb, well before midline. The same is true for interpretation in the pelvic limbs, however. In smaller animals, I will often have them stand upright to perform hopping, as I am in this patient. In the pelvic limb, if you need to pick up a limb, I generally will pick the limb up by the femur, following the principle of the thoracic limb, that if there is joint pain, the fewer the joints flexed, the more cooperative the animal will be. However, if you are able to hold the animal upright, they will often lift the limb for you, as you can see in the video, which is a reason I often perform hopping in this manner in smaller animals. Once again, we can see the stark difference between the right and left limbs. One of the last parts of the neurologic exam I perform are reflexes. We generally will perform reflexes in lateral. However, some animals will not tolerate this, and we will perform them standing. This patient is quite cooperative, so we can perform the reflexes in lateral. I start often with the patellar reflex, one because it is generally reliable, and two, most animals tolerate it without concern. Some people prefer to start with the withdrawal because when performed correctly, it is the most reliable reflex. However, the withdrawal is aggravating to some animals, and once you perform the withdrawal, they will try and stand up, making the rest of the exam more difficult. Notice that when I perform the patellar reflex, I use the flat part of the hammer, and I am looking for the distal portion of the limb to extend. My hand is holding the limb proximal to the stifle so that I do not interfere with the extension of the limb. For most patients, I will perform the gastrocnemius reflex next, because it is closest to the patellar. To perform the gastrocnemius reflex, I palpate for the sesamoids of the gastrocnemius, also known as the fibellas, keep my thumb over that region, and strike my thumb. We are looking for movement of the distal limb, similar to the patellar, And I am repeating the patellar in this patient just to compare the degree of movement, but this does not need to be done. But please repeat parts of the exam as needed to help you feel confident in your findings. For the sciatic reflex, I feel for the sciatic notch. Keep my finger in this location and watch for movement of the limb. For the cranial tibial, you want to strike the muscle belly with the pointed side of the reflex hammer, looking for flexion of the tarsus. Finally is the withdrawal reflex. I typically will put gentle pressure on the webbing of the toes, applying more pressure, but briskly, until I get a response. If there is still no response, I will then pinch the toes over the bone, and if there is still no reflex or response, I will use hemostats, but this is rare. I have to go to that level. Notice I am assessing movement of each joint, the tarsus, stifle, and hip. Lastly, I will perform the Babinski reflex, going from distal to proximal on the caudal tarsus. For the thoracic limbs, none of the myotatic reflexes are reliable, so don't feel obligated to assess them. For those interested, the biceps is performed by flexing the limb and pulling caudally on the elbow joint to get the biceps under tension, then striking your finger that is pulling the joint caudally. The region you should be holding is similar to where you would hold off for a blood draw of the cephalic vein. We are looking for flexion of the biceps when the insertion is struck within this region. Next, we will assess the triceps reflex. There are two ways this could be performed. First, we can flex the carpus, then internally rotate the limb as shown. This puts the triceps under tension, and we can strike the insertion of the triceps on the olecranon. If we do not see a reflex, like in this patient, we can then extend the limb cranially with the goal of getting the triceps under tension, then striking our fingers at the level of the insertion, as seen in the video. This time we have a response where the triceps will flex. The final myotatic reflex is the extensor carpi, where we strike the muscle belly with the pointed end of the reflex hammer. The distal portion of the limb should be relaxed and not extended, as the motion we are looking for is extension of the carpus. Finally, I perform withdrawal. Despite it being the only reliable reflex in the thoracic limb, a lot of animals do not appreciate our assessment of the withdrawal and will try and get up when it is evaluated. Therefore, I perform it last most of the time. The withdrawal in the thoracic limb took more force for me to get all the limbs to flex, but we were finally able to do it, applying more and more force for the assessment. Finally, we will check for a crossed extensor, which is present in the right limb of this patient. I find it easier to assess for crossed extensor on the up limb. However, several neurologists I have worked with feel the opposite. So find what works best for you and the patient. I did not include the following in this video because I want to drive home a point, except for the perineal, as is not something I wanted to show online. So that is why it is not included, but it is part of the complete neurologic exam. In this patient, it was normal. I did not include cutaneous truncee or hyperpathia because it does not change our neurolocalization. So let's go through the abnormalities and see if you agree with my localization. Looking at the gait, we know at least the right thoracic and pelvic limbs are affected, as there was paresis and proprioceptive ataxia in both of those limbs. This means we are either concerned about a cervical or intracranial lesion, and our proprioception agrees with this finding. To ensure this isn't a motor unit disease or a lesion in the intumescence, we need to perform reflexes, which were intact. So, at this stage, we are left with either a forebrain lesion or AC1, C5 myelopathy. Since our behavior, mentation, and cranial nerves were largely normal, we are left with one option, and that is AC1, C5 myelopathy, which is right-sided. If the cutaneous truncee cutoff was at T13, L1, I would still prioritize AC1, C5 myelopathy. The same is true for hyperpathia. If we pressed on the dog's back and there was pain at the thoracolumbar junction, I would still prioritize AC1, C5 myelopathy. This isn't to say you don't need to perform cutaneous truncee or hyperpathia on patients, but rather to drive home the point that they only provide so much information and other aspects of our exam are more important. Hopefully you found this neurologic examination video helpful. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.